We are honored to have Dr. Charles Daniel provide our next lecture. Chuck is Pharmacist-in-Chief at the University of California, San Diego, Associate Dean for Professional Practice, and Clinical Professor in the Skaggs School of Pharmacy at the University of California, San Diego. Chuck received his Bachelor's of Science degree in Pharmacy from the University of Arizona and completed a residency in hospital pharmacy at the NIH, and earned a PhD in Social and Administrative Pharmacy at the University of Minnesota. He has held pharmacy leadership positions at the University of Minnesota and Pharmacist-in-Chief at the NIH Clinical Center in Bethesda. I'm confident you will enjoy today's lecture.
Hello, I'm pleased to be with you here today, and I'd like to introduce myself. My name is Charles Daniels. I'm the Associate Dean for Professional Practice here at University of California, San Diego, Skaggs School of Pharmacy and Pharmaceutical Sciences. I'm also a clinical professor of pharmacy and the Pharmacist-in-Chief here at UC San Diego Health. I'm pleased to be able to share my ideas and thoughts with regard to medication use and medication use quality. So I will be presenting this with the focus on sort of trends and changes, but with the basic element around how medication use quality is tracked and measured. I will talk about process and tools for monitoring and improving medication use quality and outcomes. And I'll just kind of launch into the topic by chatting a little bit about the medication use process. First of all, it's a complex system. We'll talk about that in a moment. Because it's complicated, there are opportunities for error, and error could mean mistakes, or it could mean opportunities to improve medication use by better drug selection and prescribing. In the end, it impacts patient care and the outcomes of the patients that we are attempting to reach. Process improvement globally requires a lot of focus on systems. It's data-driven, and typically it requires an iterative cycle process. Let me talk for just a moment about the medication process as it's sketched out, and then we'll chat some more about the medication use process. So when you look at this diagram, essentially there are multiple general categories. The first of them is gaining history. The second is obtaining and documentation of the medication history and deciding on what prescribing should be done. After that, there's some method of transferring that information and that request to the people that will be administering or moving forward with that order. There's a relatively complex process in pharmacy that includes some manual and physical related activities, but also some activities that are related to understanding the patient, figuring out whether or not the drug dose is correct, and whether or not it needs any adjustment before it's ready to go. Following that, there's another cycle of both administrative and clinical activity that includes patient education. All of that happens before the patient gets their dose, and that's only on the inpatient setting. If you look in the ambulatory or clinic settings, it can look even more complex. The point of going through this is I want to demonstrate that because there are many steps, it gives multiple opportunities for analysis and multiple opportunities for improvement of the process. Now, the Shewhart cycle in the quality improvement activity, which is the slide that I'm looking at now, has really 4 steps, and this is classic. It's not related to healthcare, but Dr. Shewhart created a concept that is significantly has worked well in multiple industries. But the improvement process looks something like this. The first step is a planning stage. Define the data which is important and available. Define what new data might need to be collected in order to do this correctly. Plan the change, or essentially what the test is, the interaction or the intervention that is going to presumably change the results. Step 2 is implementation or pilot stage. And during that time period, it's when the change that is proposed to improve the activity goes in place. Step 3 is observation, in other words, data collection. And at that point in time, the ability to look at whether or not the intervention that you created has done its job. In step 4, essentially evaluate the data. What's important about the Shewhart cycle is not exactly the steps, but it's the fact that it is billed and implemented as a cycle. So if at the end of the first cycle you get the results that you were looking for, then good. Most times it requires a second cycle through with either major or minor adjustments to the original intervention plan. So in looking at this slide, what I really wanted to share with you is that data is the driver, whether or not it's medication errors, which this set of slides or these two graphics include, or whether or not it's optimal outcome. Data is the critical piece, and different ways to look at the data, some of which are relatively standard. And if you look at this simple diagram here, you'll see that it's really just looking at what's going on, with no adjustment for either number of patients involved. It just looks at how many incidents happened or how many events happened. And that typically is a launch point, but this slide, which really is the Shewhart run chart, is designed to actually start bringing applied statistics into your quality metrics. And in this particular case, using an upper and lower control limit helps define when particular counts are statistically significant, or whether or not it happens to be just the normal variation that you would see in data. So with that in mind, this becomes the beginning of how to implement a statistically driven quality process. Now I'm going to take one quick look at a couple of document slides that are related to computerization of the medication order and administration process. So one of the things that came out of some of the early studies into medication safety and quality were designed to look at ways to reduce variation by forcing the process to have fewer choices. One of the presumed saviors of that was computerizing the order entry process, designed, and we'll talk more about this later, but designed to improve the process, improve the standardization and reduce the variations that could be avoided. So there were multiple studies, I'm not going to go through all of these, but there were multiple studies that looked significantly at medication errors specifically related to computer order entry. And in fact, a particular study that goes back to 2005 really identified that while there may be some improvement associated with the use of computerized order entry as a medication quality improvement activity, that it also generated new types of errors. And this study was a reminder to all of us that sometimes there are unintended consequences, and the more times that you look at that cycle and ways to improve it, the more likely you are to be better. Now there was an interesting corollary to this one, and that's this study that was about the simulation of technology impact. Now that was again a prospective modeling type of an approach, but based on the data that they had available at the time, they identified that computer implementation as part of the medication order entry process was likely to save approximately 1,200 days of excess hospitalization for this particular study site, and they identified as 1.4 million in associated costs. And again, this is for one particular site. So the important point is that there are opportunities to make things better. The computer process does help in some of the variation, but it's also creates some opportunities for failure. So I'd like to speak for a short while about medication use evaluation. The reason I use this as a central part of quality of medication use is because it stands as the performance improvement method of choice to focus on evaluating, improving medication use processes, and improving patient outcomes. So there's a long list of categories of things that might trigger a medication use evaluation. This slide gives a list of those. I'll just point out that some of the examples might be new drugs, things that have been added that may be associated with disease states that are prone to problems. If it impacts a large number of patients, those are all categories. And last but certainly not least is the cost or the expense of the medication to either the patient or to the system. So with that in mind, I'll just mention that there are clearly some opportunities by looking at pretty basic information that tells you that there might be a change in what's going on or how the drug's being used. Change may be good, or it may be legitimate, or it may represent a breakdown somewhere. But in these particular cases on this slide, if you look at either antifungal antibiotics and the change between those 2 years, the last 2 years on the chart, and antivirals and the change there, those are the areas where you might be inclined to say with a change like that, something's different. So remember, what we're really looking for are items that would highlight us to particular areas of interest. The ready access to evidence-based guidelines is an important element that has changed a little bit of the landscape of being able to do medication use evaluation. The reason is that evidence-based guidelines provide the foundation for whether or not medication is being used effectively in whatever the organization is, large, small, or very small. The question is, are you using it the way the clinical evidence supports? So this National Guideline Clearinghouse within AHRQ is an important source, and they capture not just government-based guidelines, but things done by many of the major clinical academic units, chest surgeons, and internal medicine from around the country and around the world. So this is an example of one of the existing evidence-based guidelines that is available online right now. And the reason I bring that up is not because I'm going to speak more about VTE in non-surgical patients, but just because it's a typical kind of an item that frequently begins to create the foundation for what is perceived, what is expected to be the best evidence-based use of a medication. Those become the criteria that can be used by any organization that wishes to do a medication use evaluation, and it provides a source that can be used to create the criteria. So we'll go now into a couple of specific examples of MUE activities from different organizations. And I've started with this slide because this is a snapshot from the results, or the presentation of the results in this one. And what is important is that this guideline starts out by identifying, or this MUE starts out by identifying that the guideline recommendations from CDC, from the World Health Organization, and from the Infectious Disease Society of America have provided the foundation for what represents quality or appropriate use of this medication in this patient group. The second point I'll make right now is that it includes two elements. One is who it should be used in, and the other is what should be the correct dosing that goes with that. And as we get a couple of slides up, we'll see the implications of knowing that there are multiple criteria that go with this particular set of guidelines. So without going through all of these documents, I will make the case that the objectives for an MUE are probably similarly set up, and the study design appropriately created to test the questions in the particular population. So frequently, maybe almost all the time. These MUEs are not large databases. They're frequently what would be seen as a smaller, well-defined database. It could be defined by the number of patients in a given health system. It could be the number of patients that were hospitalized. It could be the number of patients that were seen in a clinic over a particular period of time. But it typically is not very large numbers. They're typically smaller. So in terms of setting the objectives and designing the study itself, it requires appropriate rigor, and it should be done in a way that allows the organization to be comfortable with the results. But they may or may not be as fully scientifically grounded as one might like to see for a double-blind study. So I'm going to just go through a couple of the findings from this particular study because I want to talk about, I want you to understand the reason that these studies imply ways to improve the quality of the prescribing. So in this particular slide, you'll see a pie diagram that basically says that 7% of the 149 patients that they looked at, 7% had empiric therapy. There was not a test, a diagnostic, and 7% had targeted therapy because they were diagnosed with, they had diagnostic data that said that this patient did truly have influenza. The remaining large percentage, 86% of this study, were patients that would have qualified for oseltamivir therapy, but did not receive it during their hospitalization. So that, I think, will help set up the conversation about what's next. This second slide here from the same data set really looked at the question of if they used oseltamivir, did they use it correctly? And I think, again, it looks like from the data that you'll see here on this part of the chart that largely the answer was when they used it pretty well. On the other hand, there was still a fairly large population, as pointed out in the last slide, that may have qualified that did not get it. So this becomes, for an organization that wants to improve the quality of their medication use, this becomes sort of the go-to point of the slide. You've studied the data, you've looked at the results, you're now at a spot of saying, so what? And that's what this type of slide is designed to do. And if you'll look here in this corner, you'll see strategies to improve, and that becomes the next steps for the organization in order to be able to be successful in their process or their activity to improve the use. So I'm going to go through one more example, MUE-related example, again to give you a sense of how this can be used to set up improved medication use activity. So this was a study looking at liposomal bupivacaine, Exparel, and this has been a somewhat controversial product across the country. And I think the question is, so if it's controversial, then why don't you study it and look at what you've done with it? So the study objectives that were presented here really focused on whether or not if you used this particular product, the Exparel, versus the alternative therapies that have been in standard use for a while, whether or not you improved post-operative opioid requirements, improved pain scores, or impacted the length of stay after surgery, all of which are important in terms of whether or not you wish to use this drug, which adds more to the cost of the hospitalization. So I won't go through this slide in a lot of detail. I'll just point out that the key point on this slide is this duration. Both of the other more traditional local anesthetics, bupivacaine or ropivacaine, have a substantially shorter duration, and the rationale for use of this more expensive agent is that the duration of the anesthesia provided after the surgery is provides longer duration, less pain, the ability for patients to get up and move faster, less need to use opioids to treat pain during that therapy. So that yellow or that red highlighted box, up to 72 hours versus 2 to 8 for the other alternatives, becomes sort of the critical question. So again, this study design, while with limitations based on the number of patients, was designed to try and answer the questions with the level of statistical confidence that could be generated out of the data. I'll go through briefly just a couple of the results slides because I think they really speak to the question. So we looked on this slide, if we look at the 4 categories, the amount of 24-hour opioid use, the stretch between 24 and 48, and the median 48-hour opioid use, I think that if the question is, does addition of liposomal bupivacaine to the post-surgical procedure reduce the amount of opioids that need to be used, it does not appear to be a statistically significant difference. And in fact, as you can see there, they are essentially the same from our data, but certainly no statistical significance. So that's one question that we felt comfortable being able to resolve. The second category slide set that I wanted to share is related to pain scores. And if you look here across there with the darker blue and the more aqua color bars being the liposomal bupivacaine and the alternative standards that we talked about earlier, you can see that there's no data to support the fact that this particular liposomal product provides better pain score if post-operative pain scores are what are used, and there's no statistical significance to this difference on any of these. Now this is the one that actually caught a lot of attention as it was presented, and that is associated with the hospital length of stay. And so if you go down to this final row here and look at median post-surgical length of stay, there is a difference between the liposomal bupivacaine group and the standard of care. Now, it's not statistically significant, so in this particular case, the MUE design would not allow us to answer that question, but it does provide an opportunity for the organization to look at it and say, maybe we need to look a little deeper into that particular question. So in looking at the results from the liposomal bupivacaine MUE, one of the important things that we want to draw out of it is that if you define the objectives well up front and you allow the data to be able to drive your conclusions, that you can make the opportunity a useful way to improve the use of and decisions about whether or not particular drugs are elements that are important for patient care or whether or not they have a different role in therapy. So it's important to make sure that I share the concept of the formulary. It's a highly misunderstood process, and essentially the definition that you see here also has not changed for some long period of time, and it's a continuously updated list of medications and related information representing the clinical judgment of physicians, pharmacists, and other experts. The reason that's important to keep in mind is because formulary is an important way to be able to apply quality decisions, whether it's about evidence that supports the use of a particular product or whether or not it's about the results of particular MUEs that have been concluded. And so effective use of the formulary is an important tool to implement quality medication use within whatever size organization you're talking about. So I won't go through the list, but I wanted to share with you a long-standing list that's called the Safeguards Against Errors on High-Risk Meds. And while not all of these items apply to every situation, one of the things that is important is that as you learn from your medication use activity, as you learn where the risks might be, wrong decisions, unknown holes in the data, it allows you to be able to start filling in how medications are used in those settings. And you might be able to, for instance, change the order entry process for a prescriber, or you may be able to change the required information that has to be submitted to an information system before you can give a patient their medications at whether it's hospitalized or in the community pharmacy. So this list is an opportunity to look at risks, and it works well along with both the MUE as well as the information system, the ordering process used by prescribers to get the best optimal use out of it. So I want to talk now for the rest of the slides that we're going to go through today about the changes that have occurred. So if the last several examples of use of localized data to try to improve quality, the expanded use and availability of EMR, electronic medical record related data, is opening some new horizons for improvements in medication use. So the examples that I'll use here, I'll talk about each of them specifically, but they represent essentially benchmarking not only across a given organization, but to look more carefully at how organizations are using medications compared to other similar types of organizations. So in this particular example that we have here, this is really a measure, a very high-level measure of observed mortality versus expected mortality, and it's pretty high level, but as it relates to medication use or anything else, in the end, the question is, what are the important outcomes? I've underlined here this particular category, general surgery, and if you run across this, this list, what you'll see is that for this particular observed mortality in this particular organization, 1.67% compares to a observed or expected of 0.73, and that puts the and that compares to the UHC, which is a comparator group in this case, median of 0.87. So for this particular organization, looking at the results of this particular multi-hospital comparator shows them to be in the 36th rank out of 131 that reported. So in that this particular measure is not medication specific, I'd like to go more into some of the examples that are out there that are more focused on medication related issues. Now this is data from a stroke category within this particular database, and in this particular case I've underlined discharge on statin medication. So this is a measure of whether or not at hospital discharge patients had been asked or had been prescribed a statin medication following their MI, and this is came again from standardized evidence-based criteria that say that patients are better served. And so if the intent is to make sure that all of your patients at discharge after MI have started with a statin, then having this benchmark to be able to compare this particular organization's effectiveness doing that compared to a larger group that is has a similar type of character is an important way to find out whether or not this organization is meeting its target. And in this particular case, it's obviously it's better than the average, and I think the idea is look and see if you're not where you want to be, then you need to figure out what the best practice is and start implementing change. This is, there's two versions of this one, and I'll just, this is what the slide looks like as it is, and this is benchmarking medication use associated with kidney transplant, DRG. And in this particular hospital, it allows one to look at the high-level numbers, but also how they've implemented use of specific drugs, along with the important piece that is available now that historically was not, and that is medication use in comparison to patient outcomes. And so this is the same slide, but if you look here at the top, I've just taken that piece that was at the top of the previous slide and I've blown it up a little bit. And so in this particular case, the target hospital is compared to Vizient benchmark group, which are identified as hospitals that have the same profile in terms of patient care, et cetera. And then also all Vizient participants in this particular database. So if you look across at the observed mean length of stay of 35 days, the expected, which is to say some variety of the risk-adjusted number for all the reporting hospitals was 35. And when you look at this, you get a mortality index that is reported here. But critically, what you're looking at is that the defined daily dose cost per case, which is a standardizing tool, defined daily dose, looks like you're getting about the same length of stay, not as strong performance on mortality, and the price of this therapy for these patients is substantially higher than the benchmark group. So this becomes an opportunity to look at it and say, here is something that we need to have a look at. And if you drill down into the bottom half of this chart, you see some opportunities that are out there. But this is the intent of doing this type of benchmarking, is to look at actual data on not only how much medications were used, but impact on outcomes, length of stay, mortality. There are multiple others. So here's another type of an example that is now available out there. If you've identified the hospital that you're interested in within this database, you can even get a list of patients that are identified in your medication use activity that had, in this case, potentially inappropriate for patients over 65 years of age. And so the column on the left-hand side is related to the Beers criteria, and I've underlined benzodiazepines. And in this particular institution, you can see that there's would appear to be an opportunity to use less benzodiazepines compared to the Vizient, which is the reference group target in this one. Again, the intent is to look at these types of data and say, is there an opportunity for us to improve? So in this particular case, if this data is presumed to be relevant and appropriate, then one might want to go back and have a look at criteria for use of benzodiazepines in geriatric patients and decide whether or not the additional risk is well suited or whether or not there ought to be an intervention to try to reduce that. A couple more examples from different globally available or some cases proprietary databases look at opportunities. In this particular case, it's liver transplant, and I've underlined rabbit ATG. And if you look across there, you can have a look at the HCO is the individual hospital, the UHC benchmark group, and then which would be those that have best practices, and then the all UHC. And if you look across there again, you'll see that there are some differences in the frequency of the use of that particular drug. And if you run down through the rest of the table, you'll see more cases where there's variability. And while variability isn't always bad, it's always something to have you look at it, especially if you have a target group, in this case the benchmark groups, that really is expected to have performed at a higher level than the average. So a couple of real quick points that I wanted to make. So if the question is knowing that you have the kind of data that we've looked at in the last few slides, is this something you can act on? This is a summary from a study that was done a few years back by some of our colleagues at the University of Kansas Medical Center. And the point of this slide is that the intervention that they used, if you will, is they started providing feedback of the types of similar types of presentations of the last few slides that I presented to you. They shared them with the service leaders, and as a result of that, they were able to change the pattern, with the UHC line, the red line, being sort of the global benchmark that for all people reporting, and the blue line representing this particular medication use in that target hospital, University of Kansas. So I want to make the case that once you know where the opportunities are, which is where some of the big data can help, as well as the MUE data that we talked about earlier can help. This is, there's data out there that says that you can use that information to change behaviors. Just a couple of last examples that I wanted to share with you. The value of some of the databases that are out there allow you to be able to look exactly at a small group of hospitals, a cluster, that are of particular interest to the group. And so over on the far left-hand column that you can't see has been removed to protect the privacy of the individual hospitals, but each of these rows then across here represents a different hospital that has similar characteristics. And if you look into the red box area, I think what you can see is, again, using that defined daily dose standardizing tool, what you can see is that not only is the cost of the drugs used, these high impact drugs, which is defined by this particular group, Vizient, and if you look at that, you can see that there are differences in the amount of drugs used for this particular diagnosis group. So these are all for the same patient group, and I don't recall right now what the disease state was, but you can see that there was a substantial amount of variability in terms of the cost of the drugs that were used, and some variability in terms of length of stay. Now, somebody pointed out to me a few days ago that length of stay is influenced by many things, and it's true, but it may also be influenced in part by medication use. So I'm not insensitive to the fact that length of stay is a pretty crude measure, but I will say it's one of the measures that are being widely used, and we need to look at that as well as some others. Now, this is a different metric that for a study that was done really some years ago, but the reason I point it out is because when you look on here, what you'll see is the purpose of this study, and this particular diagram that you've got in front of you, the chart, is to look at the number of patients that were using Novo-7, a high-cost, high-risk drug for prevention of bleed, for which it is not indicated. There's minimal data on that, versus those where it's used for treatment of active bleed, for which there is good data on. And so this allows each of the hospitals in this compare group to be able to decide where they sit. And so these are all specifically numbered so that no names of the institutions are there. But this kind of data would tell you if you happen to be the hospital that is right here, number one, on the use of prevention of bleed, that you may have an opportunity to improve your use of that drug, which impacts not only outcomes and patient results, but also impacts the cost. Lest you think that cost might not be a fair item to include in medication use quality, all I will say is that it is widely incorporated into payer metrics now, and the failure to be able to provide cost-effective care, including results, patient outcomes, length of stay, failure to be able to be competitive in that one does impact reimbursement rates. So organizations typically, whether or not they're accountable care organizations or HMOs or hospital systems, are looking carefully at that data. So, and again, this is another example of pay for performance related material. So Just a couple of last items, I think we're down to the last few slides now, that I wanted to share, and that is when you get into this question of how much can you draw out of some of the larger data sets that are now available, frequently and widely available through proprietary or group settings, the ability to look at data and the flexibility to dig into this becomes substantially broader than we've ever had before. So let me summarize real briefly right now what I wanted to share with you, and hopefully have given you some pointers toward. Medication use and the quality associated with medication use is a fairly complicated process. It is error prone. It's been shown over the years to not be easy in spite of the fact that it seems that it should be. Medication use evaluation helps direct toward opportunities to improve the use of that medication, and drug use can be improved, and we've demonstrated that through some of the slides and studies that have been presented to you today. There are substantially more pieces of data that are out there that are transparent and visible to the public. I think in the interest of time, we'll not talk about those today. What I will say is this. It's been my pleasure to share these several minutes with you. I hope you've enjoyed and learned from the lecture. If you have questions about this or any of the content, please go to the course coordinator and be very confident that feedback will get to me if there are some things that you saw or opportunities that you would suggest for improvement. Thank you.